Okay, thanks for coming when it's probably much nicer outside than it is inside. It'd be better for your vitamin D levels. So I have been tasked to talk about nephrology updates to continue a tradition, I guess, and the idea of presenting some articles that would seem applicable to general practice. I usually do my usual way of doing this, which is I tend to listen to lots of podcasts, and if things are on multiple podcasts, it must mean something. Unfortunately, there are no nephrology podcasts for this. So we're going to do nephrology updates in 4 seasons, and I hope I get the puns correct. So this is spring in South Dakota. It's beautiful. It lasts about a week or so before it gets really hot, but it's unbelievable. So as spring comes, things spring up, and in medicine, the things that spring up are new guidelines. So this is a new guideline that came out just recently from a combination of the ACP and the family practice group, which is an interesting combination of things. And you could say we have way too many hypertensive guidelines that have come out, and what do you do? And actually I've had residents ask me, what do I do on a test? I have these multiple guidelines, and what's the right answer? And so I kind of researched this for a talk I gave, and their answer was, well, use the best thing you think. So this becomes very difficult, so hopefully don't ask difficult questions for this. So the idea of this study is basically to say what do we do for blood pressure? Hypertension is obviously very common. It's very expensive, and the reason they picked the 60-year-old age group, you can see that 65% of people who are 60 years and older have some degree of hypertension. That's a huge amount of people. And for internists, these are babies for us, right? When you're 60, you're still an infant for internist. So this is a huge part of our practice. And what do we do with these people? And especially considering budgetary things at $46 billion, that's a huge amount of money. So what we do for practice is amazingly important for this. So why do this study in the first place? There's plenty of things out there to tell what your blood pressure to do. And there's a couple of concepts they had at this. One is JCC8, which is really supposed to be the guiding light. What we do is the Joint National Commission on Hypertension released its last updates in 2014. And as you can imagine, there's been 8 updates over time. And it's a pretty good update. The trouble is the SPRINT trial came out last year. I think I talked about it last time during Grand Rounds. And it kind of showed some revealing, interesting things in a very specific subgroup. And this has confused lots of people. So in SPRINT, they had a small subgroup, we'll talk about in a second, that showed if you decreased blood pressure to 120, you can decrease all-cause mortality significantly. Now, obviously, when you start reading studies, you see the word significant. And when a drug rep, if you ever see them say the word significant, you always wonder what that means. And that means a difference between 3.3 and 4.5%. So while it's significant, I've lost you. How do we get back to that, I wonder? Okay. Here it goes back. Anyways. Okay. So it clearly is significant, but the question is when you come to your clinical practice, how far do you push on someone who's 75 years of age, pushing the blood pressure down to 120 to gain benefit of a few percentage points? That's significant. In addition, when this comes back up, the SPRINT study was stopped early. So it was scheduled to go for 5 years, only went 3 years. It was stopped early because the board looked at it and goes, there's a significant increase statistically. So it was stopped. There were a lot more side effects than expected. As you can imagine, as we always worry as internists, we have older people, we drop the blood pressure aggressively, are we causing problems? There was no cognitive part of this. So no one looked at cognitive differences between aggressive less than 120 or normal 140 in a population that has vascular disease. So the question is, what do we do? So they felt obligated to do something. So the JNC8 goals, which you'll see eventually, says general population greater than 60 years of age should be less than 150 over 90. That's been accepted. For the population less than 160, we talk about less than 140 over 90. And then if you're greater than 18 with coronary artery disease, with chronic renal insufficiency, CKD, it should be less than 140 over 90. There we go. And if you're a diabetic, it should be less than 140 over 90. That's been the guidelines for quite a long time. What we choose in JNC for the students in the room, the goals are one thing. What JNC really is powerful for is what medications you choose first. And that's changed tremendously for the first part. It was always a thiazide and a beta blocker first, and you can see as you've got more drugs that's evolved through time. The SPRINT trial looked at a population greater than 50 without diabetes, without a history of stroke, without symptomatic heart failure, without proteinuria, and do not reside in nursing homes. The question is, does that reflect your practice when you see these people in your office? It was patients that had some degree of coronary artery disease, some degree of peripheral vascular disease, some degree of cerebral vascular disease, except for CVAs, and that's usually TIAs. And I'll tell you, in the neuro community, TIAs are thought to be strokes. You just can't catch them. As we have better MRIs, we actually see changes. And there's great studies looking at patients with small vessel disease that we now call strokes that evolve. If you do an MRI every week for 6 weeks, you see evolving strokes. So these aren't TIAs, these are strokes. So the category may change sometimes. Or have a estimated GFR between 20 and 59 or greater than 75 years of age. And in that population, if you drop blood pressure to 120 to 125 over 90, you'll have an improved outcome, as we talked before, 3.3 to 4.5%. Not huge. These are the current guidelines out there. They're dizzying how many there are, and depends on which society you belong to and who you believe. And obviously, when it comes to board testing test, there's nothing that says American Board of Internal Medicine on there. So which ones do you choose? And that makes it a difficult part. Methods of this was a review. I thought it was interesting that it was the ACP in family practice when it was a VA-based study, which I usually don't think of FPs in family practice at the VA, but obviously they have family practice as well. I would say that it was a little more heavy-handed for ACP, the American College of Physicians, and family practice was involved in this side. They reviewed lots and lots of things, as usual, in many studies. We'll go over that in a second, I think. So first recommendation from this group is that they recommend initiating blood pressure control for 150 over 90 for patients greater than 160. So no real difference from there from GNC. And that was based on strong recommendations based on mortality, stroke, and cardiac endpoints. So hard endpoints were definitely improved if you did this there. So that's not much different than before. Now it gets a little gray. The second recommendation is for the same group of patients greater than 60. If there's a history of a TIA, which I said is really like a stroke nowadays, that you should look for blood pressures of 140 or less, not 120 over 90, but 140 or less. So they're not going quite as strong, and that's based on weak evidence, because they felt the evidence for dropping it further was not very strong, based on multiple analysis. The second one is for people with high-risk cardiovascular disease. That would be from Framingham scoring, basically. They also think decreasing the blood pressure to 140 or less is good because there's some weak evidence that there's improvement. So really, we're back to 150 over 90 for the general population greater than 60 in this recommendations. And if you have cardiovascular risk, now they don't include in here diabetes or anything else. They just say that if you have cardiovascular risk, you should decrease your blood pressure to 140 if you wish. They bring up a couple very interesting points, though. I think it's not represented in other blood pressure trials. One is there's very few trials with multiple comorbidities, which is the people you see in your office. Rarely do you see, I'm just a diabetic hypertension with no kidney disease. I never had a stroke, but I have isolated hypertension. So isolated hypertension in the elderly with no other comorbidities is an unusual thing, and you would say is what we don't want to see, right? We tell people the reason we treat high blood pressure is because you decrease risk. So if they come in at 90 years old, the blood pressure of 180 over 90 with no problems, is it even ethical to treat them because they have nothing? What are you going to stop going on? So rarely do you see people without other comorbidities. The other part is there's no evidence to even look at diastolic blood pressures. So all these studies always say 140 over 90, and if you're in medicine and you see people more than 30, you never see people with a diastolic blood pressure of 90, right? It's just impossible. And if you do see one, they shouldn't be treated, I would argue, because those means they have an incredible elastic recoil of the vessels, right? As we all get older, our vessels become harder, so you can't generate a diastolic pressure that high. It's impossible. If you do, your vessels are wonderful. They actually recoil. So it doesn't happen. So I see nurses give me a report, or I see from the computer that my 90-year-old has a systolic pressure that's 180, I believe, but I see anything above really 80, I never believe because there's something in error in there. So really, you can skip the 90 part. You probably just have to worry about systolic pressures only because that's where the money's at for this. High-value care is the next interesting concept. So they're questioning whether there's beneficial. So there's this shared risk thing that goes on, and you talk about dropping blood pressure lower and lower, and there's lots of things. There's compliance. So in the SPRINT trial, the majority of patients were on 4 medications to achieve a blood pressure less than 120 to 125. As you know, the adherence to 4 medications for blood pressure alone, that's not their diabetes medications, not their cholesterol medications, not the aspirin they're taking, not the vitamin D they're taking, the vitamin E and everything else, is probably 0. We work heavily with compliance and transplant. I have a pharmacist and a nurse that interviews every single patient in there and talks about how many pills they miss. And it's not great, and those are 2 medications. Imagine 4. right? If you work in clinical medicine, you know that doesn't happen, or they're lying to you. So to achieve this goal in a research study is great because, again, in a research study, you have research assistants that call up the patients every week. How are you taking your medications? That doesn't happen even in medical home issues. And also multiple complications that occur as well. So addressing high-value care, I think, is a very interesting concept for the ACP to talk about, is really we should be treating the patient, which is quite a concept. You know, it's just not the numbers. A little better. The other part, because I'm classically not a guidelines person, is that all guidelines are guidelines. So there are people in the world, we'll have an example later. I had a friend that said there are people who put ketchup on hot dogs and people who don't, right? That's the world. There are people who follow guidelines usually the letter and can't stray, and people who look at it as guidelines. I'm a guideline sort of person. They look at these guidelines. So if you have people in your office and they fit a certain pigeonhole and you only control the blood pressure in a certain range based on a study, you have to look at the whole patient. Again, these are guidelines. Now, unfortunately, guidelines turned into rules. So nephrologists are very aware of this. So many years ago, we started having guidelines for treatments for dialysis, guidelines for PTH, guidelines for albumins. And what happened, and the government came along and said, those are great guidelines. Let's make them rules. If you don't achieve those rules, we won't pay you. So unfortunately, while these are guidelines, they become hard and fast rules after a while. So bottom line, strong evidence to keep your blood pressure less than 150, maybe over 90, would maybe diastolic doesn't make a difference at all. If you have someone who is greater than 60 that has a history of a CVA or TIA that has cardiovascular disease or cerebrovascular disease, probably less than 140. It's weak evidence, but you can do that. Again, the 90 doesn't make any difference at all, probably. Also consider lowering blood pressures for patients with high-risk cardiovascular disease. Again, that's assuming you're doing Framingham risk analysis on your patients. Weak evidence, but you can do that as well. The SPRINT population had decreased all-cause mortality, yes, but it was, again, 3.3 to 4.5, but increased risk of electrolyte abnormalities, syncopal episodes, no unchecked cognitive decline as well. So the question, are you getting some benefit, but you're suffering from the other side of complications? And obviously, if you have someone who's 75 years of age and they have atrial fibrillation and you bring their blood pressure down to 120 and they fall down, they come see me for intracranial hemorrhages and things like that. Or if their cognitive function declines, again, we're trying to improve quality of life. So living to your 100 with depressed cognitive function may not be that. And the core studies, remember, really looked at diabetics, and there was no benefit from dropping blood pressure less than that. So in basic reality, we kind of go back to JNC8. Now, for people taking the boards, I don't know what the right answer is. Again, it wasn't like the American Board of Internal Medicine adopted anything. I would say the ACP is probably as close as you can get to the American Board of Internal Medicine, but it makes it very difficult. Yes? 2014. Not that long ago. Sprint 2015. That would be the best answer. So, again, it's hard. And again, as you know from the board questions, right, they're pooled, they're old. It's, yeah. So you're not even there yet. So hopefully Sprint doesn't come through. Yes, yes, sir. Yeah. That was because they saw benefit early and they stopped it. Efficacy. And you could, yes. Well, they were pretty aggressive on their recommendations for Sprint. They said you should do this to these people because it would do better. I think the ACP that went back and goes, well, what's the evidence that it really works for this? And I kind of see this as a research trial, right? They did the research trial, and then a clinicians looking to go, yeah, but this doesn't make sense because I have patients having problems. And one thing I rail against is the significance. I mean, obviously there's scientific value and there's p-values, but when the difference is a percentage and a half point, how much investment do you do for pain and suffering in the backside to gain that 1.5%? If it was, 10% from 50%, you could argue something huge. Okay. Next is summer. So this is summer for South Dakota, right? It's hot, it's sweaty. I've never been there myself. People don't wear a lot of clothes there, I understand, so it's probably getting some sunburn as well. And there's lots of consumption of probably non-vegetarian foods there. So this is a very heavy meat thing. I'm from Wisconsin, so to me, this is summer, right? It's bratwurst. So it's the correct way to make bratwurst. So everybody knows that you should make bratwurst by first boiling them in beer with onions, then you grill them and put them back in there. So if you're going to do that, that's the way to do it with the beer on the side. Both of those are stone wrist, though. So I think of those as stone risks. Alcohol is dehydrating, right? So now you're dehydrated. So you have increased risk of stones. And the question is, if you eat too many brats, you have increased risk of stones as well. So that brings up the NUT study to look at dietary protein and phosphorus or potassium intake and whether it affects kidney stones, which is a very interesting concept, kind of brought on by multiple sort of things. There's a big Wisconsin theme for this. So should we look at this and see if there's any difference? There's a way to decrease this. Now, stones are one of those things that I think nephrologists do, but people forget. So to put a plug out for nephrologists, we would say nephrologists treat your kidney stones and urologists just take them out. And I don't know if there's any urologists on the line here. I really doubt that. We would say that there's no reason to stop making stones because you can take them out. For nephrologists, the idea is to stop them from forming in the first place. So if you're doing primary care or you have somebody with stones, we would typically say after your second stone, you should see someone who's going to do something about stopping them from forming. So a lot of our training is how to do that. And there's something called the stone clinic phenomenon. Just show them to a stone clinic, you have a decreased risk of developing stones in the future. It's not because nephrologists are great, which you could argue back and forth, but there's been no blinded study for that. But we tell you to drink water. So drinking 2 liters of water a day alone decreases your risk of developing stones. So the question, are there more things to do? In addition, stones are like pretty easy on the surface. You go, well, it's just calcium, decrease your calcium. If you know anything about stones, decreasing your calcium in your diet actually increases stones. It's much more complex and it's getting more and more difficult, and actually the physiology gets amazingly difficult. So protein in stones, who would think? So higher animal proteins, bratwurst, is associated with an increased urinary calcium and uric acid. So both those things in your urinary tract are just looking to jump onto something. So if you have calcium floating around, it wants to form something, it forms a solid, you get a stone. Also, you reduce urinary citrate. Now, citrate, kind of calcium can go out, but calcium forming with phosphorus is a whole different story. So you have an increased risk of stones, and you have a more acid environment. So there's this huge acid output from what you eat when it comes to animal-based proteins. Higher dairy-based proteins are associated with increased potassium intake, just in general because they're associated with each other. And interestingly enough, supposedly a decreased urinary calcium, and therefore a decreased risk of calcium stones, which doesn't make a lot of sense because you're having more calcium in your diet. Well, the problem is it's not with the calcium, it's what it binds with. So that's why we say decreasing calcium in your diet typically increases your risk of stones because it's going to be things oxalate. So oxalate, for example, floats around. If you have a lot of oxalate in your urine, calcium is going to bind. If you take a lot of calcium, it binds it in your gut. It never gets to your urine. And diets and high in fruits and vegetables, or plant-based diets, as we say nowadays, have very high levels of potassium citrate, and therefore should still lower the stone risk. To continue the Wisconsin theme, the basic physiology is worked out at MCOW years ago, and it's quite complex. So increased potassium in your diet is associated with a lower sodium intake, and that's part of the whole DASH diet, right? So if you have high fruits and vegetables, by nature, you tend to have lower calcium or sodium. Lower sodium makes a difference because if you have lots of sodium in your urine, you try to get rid of it. If you get rid of sodium, calcium's got to change because it's the same charge. So you can't get rid of effectively sodium and calcium. And that's why thiazide diuretics work very well for bone density, right? So if you're on a thiazide diuretic and you get rid of a lot of sodium because of that, you hold on to calcium, your bone density increases. Higher urinary potassium is also increased with renal tubular phosphorus absorption, that's the study, and therefore increases 125 and decreases urinary calcium because you reabsorb those things. So again, this is fairly complex physiology worked out years ago at MCOM, or Medical College of Wisconsin. The next part, same group study, looked at the importance of net renal acid excretion. So when you eat something, you got to break it down, and it breaks into many things. And one is, especially animal-based proteins, are high in sulfur. So if you go way back to biochemistry, you remember the amino acids associated with animal proteins are high in sulfur, which of course is an acid, and associated with decrease in urinary pH, and associated also with high urinary calcium levels. And a plant-based diet tends to be low for acids you generate. Here's a list of things in the acid and alkalins to secrete, and you can't say that vegetarian food is without acid secretion. But in addition, these are normal meat intakes, which again, if you live in South Dakota or Wisconsin, is not the norm, right? These places tend to eat lots of meat. So if you're in Europe, it's one thing, but there's much more meat being as far as turkey, veal, and beef. The only thing that the vegetarians get hit with is brown rice and things like that. They have a little less of that, but it's countered by things that are negative. It actually makes it alkaline. So having a balanced diet probably is the key, though vegetarians are obviously better. So why do this study? Well, there's very few studies looking at protein sources in stones, except for oxalate from some meat. Most prospective studies for diets are stopped early because no one can apply or adhere to the diet. Most of the observational studies are conflicting. And while potassium citrate's been used for years to decrease stone risk, there's never been a study, and Wisconsin and Broad are the next research. Okay, study population looks at the health professional follow-up study, which includes, which I didn't realize until a couple days ago, doesn't include what we call allopaths. It's dentists, optometrists, osteopaths, pharmacists, and podiatrists and veterinarians, but not allopathic physicians, which is kind of strange. I don't know why that was excluded. Nurses' health study, as you know, is famous. 1 and 2, obviously different kind of age group, and there's some differences in race, things we'll see later on. And they use this because they collected tons and tons of data for these patients over many, many years. Assessment of diet, they did questionnaires, and they did this ahead of time, right? Obviously, they started this in the 80s, so they've been doing this for a very long time. And it will take about 130 different kind of foods, 22 different beverages, and they correlate them. Some things they didn't have numbers for, and they actually did punctures into food to figure out the amount of nutrients in there. Diet-dependent loads or diet net acid loads were calculated. There's a way to do that based on the food you take. There's this kind of cool formula you can do with it, and they can figure out the acid secretion and production does at that point as well. They did 24-hour urines. Obviously, they did them ahead of time. They did them in different cycles, and this is where race is a little strange. So NH1 was very heavy in, because it started early, was Caucasian female nurses. So 2 was more recent, so there's a lot of patients that are not Caucasian nurses. So they had to exclude 2 to just include Caucasians to make this a little balanced back and forth. So they're very exclusive group here. So these are the professionals you heard before, and this is really a Caucasian-based thing. And they checked urines in multiple sort of cycles. Here's a cohort scene, so average age in the 50s, except for the NHS2, which is a younger set of nurses. BMIs, remarkably, are pretty good. Diabetes is very low across the board. Hypertension, which is, again, this is meant to be male-female, not that there aren't female veterinarians and dentists and everything else, but you see much higher risk of hypertension, so this must be bad career choices in general to go into. And the alcohol intake is much higher as well, so they're obviously must be depressed, hypertensive, and drunk most of the time, compared to the nurses who are more upstanding citizens in the world. Otherwise, it's pretty close across the board. So, first one, result came back. Potassium intake is inversely related to stones, which is a great p-value across all boards. So if you had increased potassium intake in your diet, which is typically plant-based or just because of the food you choose, you have a decreased risk of stones in general. And that's independent of age, BMI, or the use of thiazide diuretics. Again, thiazide diuretics change what your urinary output looks like. Net acid load is directly related to stones. The more acid load you have, the more likely you have stones. And this is controlling for potassium and animal protein intake. So this is just protein intake in general. Things are going to generate a acid load, not an alkaline load. And across the board, again, control for age, BMI, and thiazide diuretics. Dairy versus animal protein is not quite as cool. So dairy protein, you had more calcium in your urine, which makes sense if you're having more milk. You had more citrate in your urine, and you had increased production of calcium and phosphorus, both are obviously in dairy sort of things, but lower oxalate. So oxalate is usually associated with animal-based proteins, so you have less oxalate stones. But there is a supersaturation point of calcium phosphorus that's closer, and that's an increased risk. Animal proteins, you had increased uric acid, which makes sense because you have all those extra proteins like that. Supersaturation of uric acid, lower pH, and more citrate. So supersaturation is something we think about in nephrology too, is so if you've done the crystal experiment, right, you add sugar to a solution, and it gets to a certain point, you put a string in it, it forms a crystal right away because you hit that max load, so it's supersaturated with crystalline structures. So that happens in your urine too. So one thing we look at saturation points when we do 24-hour urines. So we look at more than just calcium and phosphorus. We look at the saturation issues, and if your saturation point is that you're going to form a stone with one more drop of sodium or calcium, you just increase your volume and decrease saturation points. So for us, saturation points are a big deal. So there's an increased risk because of calcium and phosphorus in the dairy people and the animal proteins in the uric acid. Unfortunately, they didn't do just vegetarians, which I think would be an interesting point, but it's going to be hard to bring out for vegetarians, almost be a vegan, which is going to be a much harder thing, and there's very few vegans probably in these studies, especially the old ones. There is an association between potassium intake and urinary composition. The fact that high potassium intake is associated with higher urinary volumes and lower saturation points for oxalate and uric acid, again, because you have increased volume, you have decreased saturation points. And weirdly enough, no association between potassium intake and calcium excretion, which was thought back in the original studies. That was kind of blew that one out of the water. There's also increased acid associated with lower pH as you have increased acid load, you have lower urine pH and lower volume as well, so increased risk. So conclusion of this analysis was non-dairy proteins is associated with increased stone risk, so the animal-based proteins, especially in men and older women when compared to plant-based diets, or it'd be high in fruits and vegetables. High potassium diets are associated with lower stone risk, and higher net acid loads are associated with higher risk. So if you're counseling your patients, you would say, what we're supposed to be probably saying anyways, is that a plant-based diet, or at least a diet high in fruits and vegetables, are good for you. From the hypertensive side, that's been proven because of DASH diet, but less protein intake via meat. So bottom line, a diet rich in fruits and vegetables, or at least abundant in them, decreases your risk to have stones. Yes, sir. No, it is, because you have decreased urine calcium. You think it would make a difference. But I think it's because it's also stones are amazingly there's like general physics, simple stuff, mass action, and there's quantum. So really, when I was a fellow, it was just basic classic physics, right? Nothing much more complex than that. And then we started learning about all kinds of proteins that hang on the tubular systems. It's much, much more complex than that. So I think it's a simple question, but yeah, it did make a difference. I was surprised. So the answer to the question on the thing was, which do I choose, the meat or the tofu? And the answer would be the tofu. Now, as a vegetarian myself, the most disturbing thing at the end of the picture is ketchup on a brat, which is just a wrong thing to do. Anybody put ketchup on hot dogs? No talking. So next one is football season, so it must be fall. So obviously football is big here from high school, grade school, and college. And fall is not only football, but since we all have been going to college for a long time, it's also results. So this is a study about how accurate is a blood pressure in your office. And the reason this is important because these results go to lots of things, right? These results indicate your scoring systems, even sometimes reimbursement, and we pray to this golden cow of blood pressure. So in ICU, we had this long discussion with students and residents, is what is blood pressure? And I go, I don't know. Because I can put a catheter in your wrist, I can put a catheter in your brachial artery, I can put a catheter in your groin, I can put a catheter in your foot, and your blood pressure is all different. Now that makes sense physiologically. I can put a blood pressure cuff on your arm, your leg, it's all different as well. So which one is the correct one? And classically in sepsis, it comes, someone comes in as a junior fellow, and they come in with from the floor, and the nurse says there's a blood pressure of 150 over something really low, and they're pale, and they put an A line in the foot, and they go, the blood pressure is 100, they're doing fine. Well, the blood pressure is supposed to be higher in your foot, right? So that's the ankle brachial index. It's supposed to be at least 1.5 times as high. So it's a common error, but it really depends where you measure it, and it's very confusing what things are. Now, standards are, we use a cuff for blood pressure. How accurate is that? You can argue a lot, right? You have people with big arms that is hard to compress. There's errors in the way you take blood pressures. There's errors in the way it's recorded we'll go through, and many, many errors in the way we just do basic blood pressure measurement. So it's one of the things that we talk about a lot. So, some trials, when Norvasc first came out, it was, drop your blood pressure by 5 points was a huge difference. There are things that drop your blood pressure by 20 points just clinically in the office by the way you set. So it's something we don't pay a lot of attention to, but makes a big difference, especially if you're talking about what's going to happen as far as scoring system. So why do the study in general? So most blood pressure trials are done with ambulatory blood pressure monitors, which I was a member of the American Society of Hypertension. We would say, yes, you should ever do another trial without ambulatory blood pressure monitoring because that's the best thing to do. And if you take care of people with high blood pressure in the office, you realize that office blood pressures now are not very accurate. Home blood pressures are probably better, but it depends when they take them. In most trials, they have you sit in a room with an automatic blood pressure cuff without anybody around you. Take your blood pressures 3 times and average them. That's the way these trials are done. How often do you do that in your office, right? So we don't do those things in our office very much. I think everybody knows about white coat hypertension, but there are many things that happen besides white coat hypertension. There's even a cool thing called reverse white coat hypertension, which is demonstrated in some of these studies that your blood pressure actually goes lower in the office than it is at home. Hence, ambulatory blood pressures are probably the best thing to do. And no one reads the first chapter of the book. So this is Kaplan. So Kaplan, I think, is still alive. Kaplan was the Department of Medicine chair and then hypertension at in Texas for years. And he is now I get old enough, he has always written the best single author hypertension book in the world. So if you take the boards for hypertension, this is the book you read. Now this is the book I read. It's now up to the 10th edition. And now he's a co-author because he's getting older, plus he has a co-author for some pediatric issues. But the first chapter in this book is how to take a blood pressure. And no one reads that chapter because we know how to take a blood pressure. And we blow off all the important things that make a difference. So they looked at all these things in this study. This is from Australia. To find out, is there anything that makes a difference in blood pressure? And you're not meant to see what those all are. So they did the typical sort of analysis, looked at lots of studies, weaned them down, and did an analysis on what would make a difference for summary. And in the end, they had 328 articles to look at. This is the outcomes of the study. We'll go through them in detail so you can see lots of pluses and minuses all the way through. The first one, we'll start from roughly the lowest thing to the highest, is acute meal ingestion. So does eating a meal just before they come in make a difference? I stopped by McDonald's on the way in, and you could argue about sodium content for that. I did something I didn't have anything to eat. Was it make a difference? And in general, it doesn't make a huge difference. So -6 for the systolic blood pressure, -5 to 1.9. Now that kind of makes sense, right? If you have a big meal, you dilate your splenic circulation, you take volume away, so your blood pressure is supposed to drop. That's why you get cramps when you go swimming, right? That's the mechanism, because you alter blood flow. So after a big meal, it goes to your stomach, not your muscles. So if I open up a vascular bed, it's going to cause my blood pressure to drop. That's what happens with calcium channel blockers, right? I dilate. So of course it's going to make a difference. Now, whether it's a big meal or small meal make a difference. If it's been a lighter meal, it doesn't make much of a difference. But if you have someone that comes in that's hypertensive and you can't get it under control, you should ask them to go someplace and eat like the Royal Fork first, because it may help it. Because 6 points off of blood pressure can be a difference, right? They're like 145, I can't control them. Go to the Royal Fork, come on in, I'll take your blood pressure right away. It's 138. We win, right? No changes at all. They may die of something else, but that's a different story. So not much difference there. Alcohol intake is probably more of an ICU sort of thing, or hopefully not in your office. But it can make a difference too. So one, it goes from there being really, really drunk to being agitated probably. So if you're having patients who are intoxicated, you want to take the blood pressure right away for goal, because if you're acutely intoxicated, it's a vasodilator again. If you're kind of withdrawing, it's going to go high. So not much of a difference, and hopefully you don't have to take care of that in your office. In the ICU, it makes a difference. When I take care of people with head injuries, the blood pressure dropping by 23 points is sometimes a difference between perfusion of your brain and not. It's not a huge difference. Paretic arm, I was always taught never take a blood pressure in a paretic arm because your blood pressure will be lower. In fact, it doesn't make any difference. It may be 2 points higher, not much. So feel free to take it in the paretic arm as well, so no differences there. And again, that's the arm and not the leg. So now we get into some things that make a difference. Reliance on a single blood pressure. So typically you take one blood pressure, and at least I was taught years ago with no real evidence, I don't think, that if you take a blood pressure, another blood pressure, another blood pressure, another blood pressure repeatedly, you cause arterial spasm, and you tend to get a higher blood pressure, goes up further and further and further. So you're supposed to wait between them, but you should probably take a couple blood pressures. And this becomes an issue with an office, right? You have people coming in quickly, your nurses trying to room patients quickly. To sit down for 10 minutes and get a blood pressure is going to be difficult. But also, patients like me would come in very late and rushed and just ride my bike, and you take your blood pressure right away. That's probably not realistic to do either. So some period to rest is obviously good. If you're slow in clinic like I was, it was great, but then they were angry when they saw me because they waited too long. So waiting for sometimes makes a big difference. Insufficient rest period is the same thing. Talking, so if you talk during the time you're taking blood pressure, it can make it a little higher because people get a little anxious during those times. So you're asking history, right? You really do talk about the weather. I mean, and I used to, we do blood pressure measurements. My typical thing is when you come see the doctor, unless you're pregnant and want to be pregnant, it's never good, right? So if you're there to have a baby and you're happy and everything's wonderful, but rarely do you see a doctor for a good thing. Even internists, right? I'm sick, I'm getting my medications changed, you're going to tell me something horrible. As a flight surgeon, it was always, patients were freaked out because I had the ability to take away their livelihood. I could take away their license to fly. If you're a neurologist, they would be able to take the ability to drive. So they come to your office stressed out, right? They're going to hear a bad thing, I have cancer, something horrible is going on. So it depends what you talk about, but clearly if you're asking history, the blood pressure can go up with that as well. Smoking, I was taught didn't make any difference, and this study said it does make a difference, and it depends how fast they just had a cigarette. But smoking does cause some vasoconstriction right away. That's why you get that sort of lightheaded buzz. So if you get someone who, hotbox we used to say, smoke a cigarette really quickly outside, it smells a lot like cigarettes, it's going to make their hotbox. Any ex-smokers in here? Oof, wow, that's really good. So, so you can smoke a cigarette and you just smoke it really fast. So you're waiting to go in the doctor's office. Instead of puffing on it quickly, you just suck the whole thing down quickly. And the nicotine is a little higher that way, and it's really hot. So I'm an ex-smoker. So it does make a difference with blood pressure. Caffeine use, so your patient stopped by Starbucks on the way, a little bit of difference in the blood pressure, not as much as you would think. You think it would be much higher than this. But usually because caffeine use is habituated. So rarely do you have things that make a difference, and cigarette smoking is the same way. So theoretically, if you don't smoke and you did this, you actually may be a little more hypoxic, and you may shunt some blood around, and your blood pressure may be lower during those times. But most smokers aren't just doing one-time cigarettes, they're habituated to it. Caffeine is the same thing. So probably most people in this room are somehow habituated to caffeine or something, through sodas or coffee. So it's an habitual sort of thing. So if you never drink coffee, or you drink 5 espressos and go in, you'll be more tachycardic and blood pressure goes up. Body position varies quite a bit, from a negative to a positive, and that takes into account for everything. There are legs crossed, they're back supported. Ideally, you're supposed to be sitting flat, knees bent at a 90-degree angle, back is supposed to be supported, arms supposed to be lower than the heart, and supported as well. I was at an institution someplace else, and they took my blood pressure basically standing on one foot, staying up like this, trying to balance. It's like that was not a very reliable blood pressure. I was kind of pissed off at it. So position makes a difference. White coat effect. White coat effect goes both ways. You would think that we would usually say that white coat hypertension is the most important thing we do, and in fact, it can drop your blood pressure as well, because there is reverse white coat hypertension. Most studies have been done really with ages and ethnic groups, not just a white coat. And as you know, it doesn't make a difference if you wear a white coat or not. It's just coming to the office, and I think it's mostly because the doctor is going to tell me something horrible, right? I have something bad happening. Again, unless you're going to find out you're pregnant and you're happy about it, there's never a good time to go to see the doctor. So white coat effect, clearly different. But bigger things are things like this, bladder distension. So bladder distension is known to really increase your blood pressure quite a bit. And then even in people with paraplegias, it's one of those things you see. So if I'm a quad and I'm not cathing myself enough, you start to get this huge sympathetic tone. You'll see these people sweat and have this weird feeling of pain, and their blood pressure will shoot through the roof, and you put a Foley catheter in them, and everything gets better. So if you come to the doctor's office, one thing you never do is you never empty your bladder, because they may ask for a urinary sample, and you're always freaked out about that, because, oh my God, they're going to ask me for a urine specimen, and I'll be very nervous because I can't go in the bathroom, so you come really full, right? So this is the first thing that comes in your office. So clearly it can make a huge difference, especially if you have a lot of water. So I didn't drink very much, and then I slammed a liter, and then I had to go like crazy. So this is going to affect your thing. And rarely does your nurse say, unless it's different than my office was, you usually get your blood pressure first, then you go to the bathroom to get your urine specimen. So it should be the other way around. So a big difference. Cold exposure, which is a big deal here, right? How many times do you say the patients, usually there's a shoulder season, but usually the rooms are too cold. They're freezing in those rooms. So cold exposure increases blood pressure tremendously, up to 30 points higher. That's a huge difference in blood pressure. So trying to keep your rooms warm, and again, we take care of old, frail people. So you have this old, frail woman with a BMI of 16 who's freezing in the fall, and she's going to have higher blood pressure. This I find disturbing. So it's not just bad now since we use automatic blood pressure cuffs, but in the past, people like zeros. So there's a digit preference, and maybe the digit preference is 2. But people will take a blood pressure. The example here would be 117, 122. They're going to say 120 because it's just rounded. So if you're taking a manual blood pressure, so you shouldn't even really do that because it should be graphed because it's not that accurate. Most measurements are within 3 points anyways. So the question is, when you're having a blood pressure the old-fashioned way is even very accurate because people write down different numbers. So up to 80% of most of people have the wrong digits down. Devices, now the gold standard is a catheter. They don't say where they put the catheter in. They usually would say it's going to be a radial artery catheter is probably the best place to do it. But the blood pressure, again, is different in the wrist than in the arm. So there's a big difference in blood pressures. So invasive versus mercury, I always thought that mercury was the best. And actually I was taught that a nephrologist does rounds with a mercury thermometer at their bedside because the nephrologist doesn't trust anybody else's blood pressure. And that's obviously an old concept because I haven't seen a mercury-based thermometer or a blood pressure cuff for a long time. The mechanical ones work very well. They're a little better. Calibrations are off quite a bit. You can see calibrations can be off by many percentage points as well. So it depends how well you're calibrated as well. Home blood pressure cuffs, at least by European standards, are plus or minus 10%. That's good. The Americans have never really put forth a standardized way to test these things. If you have people doing ambulatory blood pressure cuffs at home or doing their own blood pressure, they always have come in for validation studies. So they come in once every 6 months. They bring their cuff in. I know their blood pressure is going to be higher in the office than at home, so we take blood pressure with the cuff and with our cuff to see how close they are. And with them 10%, they're okay. Bottom line in this whole thing, there are 25 different things that affect your systolic blood pressure, 27 that affect your diastolic blood pressure. So taking someone's blood pressure in a cold room who's just smoked a cigarette and has to urinate is not a true blood pressure. So again, these are things you're scored on. So simple things make a big difference. So in this patient, their blood pressure may theoretically be 30 points higher. And if you have someone in there and you don't ask these questions, your thing is, I'm going to start maybe 2 medications on you, right? So some studies would say if you're in the 170s, there's 2 meds you start. So now you took someone who maybe have a normal blood pressure, start 2 medications, and they fall down and have complications. Consider recording blood pressures in graphic form because it's not that good. So there's differences. And if you're good enough, I used to know the numbers, there are certain numbers at a automated blood pressure cuff cannot record because it's a program. And if you, I don't know if you know, the ones we put on all the time in the hospitals don't measure blood pressure, they measure MAP. And they calculate the 2 ends. So there's certain numbers that are impossible to have because the calculation doesn't do that. So how good is that as well? Try not to treat blood pressures on a single blood pressure reading. I know we don't try to, but that's sometimes in the office. And consider either home blood pressure cuffs or ambulatory blood pressure monitoring. Both I think are probably the best. In transplant, blood pressure is a huge deal, as every internist office, and we rely a lot on the home blood pressures because they come in and they're very anxious about the transplant. I'm going to reject everything else. So home blood pressures are a big deal. We talk about home blood pressure should be done the exact same time. Obviously, if you do ambulatory blood pressures, you see diurnal variations, right? Your blood pressure increases or decreases through the day. So blood pressures at the same time, 7 o'clock every single day, and then we always just say before they watch the news because it's very disturbing nowadays. And then extra credit in the afternoon, same thing. Okay. Last section is winter. So winter in South Dakota is depressing. It feels like death to me sometimes. So this part of the year is like wonderful, especially biking, right? Biking in this is just depressing. So this is the coffin. So this is looking at the effectiveness of doing renal artery stenting. So back in the early 2000s, it was very fashionable to stent renal arteries, and it was very lucrative. Nothing against cardiologists, but the classic saying when I was a fellow was that a cardiologist could charge the same amount an internist makes in a week by just squirting contrast in the renal artery and recording it. So it was very lucrative. And stenting it was very good too. And if you've been in this for a while, surgeons always claim to cure things. So for a while, vascular people claim to cure hypertension. And for years, neurosurgeons have been trying to claim they can cure hypertension by doing surgery in the posterior fossa. And it kind of comes for a while, and it's a big deal, and then it kind of falls away. So there's always these claims for things. So it was a big thing, and we would do more and more studies, and we had things about if you're 70 years old and smoking and male, you probably have increased risk of renal stenosis. And you would come into my office, and we would say you have renal insufficiency because of renal artery stenosis. So we did lots of cracking, we would say. Then we learned that some people didn't make a difference, like fibromuscular dysplasia doesn't make any difference. And we kind of figured things out. And then it kind of got a little worse, and we said, I don't know if this even makes a difference. And that was based on 2 studies. One is called Coral, and they were both in 2017 in Astra, and they were negative studies. And things started to get worse, and then we realized that maybe it wasn't the best thing to do. And really the purpose of this study is to kind of put the final nail in this concept. So Coral was, again, from 2007, was in New England. And you can see the differences between outcomes in the blue and the yellow between the 2, renal stenting in blue, medical therapy in the gold, and there was no significant differences. And there was significant problems with complications associated with stenting. So but based on Coral, there's no difference in outcomes in kidney function, no differences in hypertension. Then Astral came along as well in New England, and same thing. There are things we found substantial risk, but no evidence associated with revascularization. So this study was meant to be the final piece because it's still being done. This happens in medicines a lot, right? So one of the things close to my heart is dopamine, renal dose dopamine to help renal perfusion, which has been proven over and over again not to be effective, and just probably in the last 5 years has been stopped. It got to the point in up to date, it actually went as far as saying you're kind of open for a lawsuit if you do this, and that's how far it had to go. Or sublingual precardia, right? When some of us started in medicine, everybody got sublingual precardia, drop your blood pressure, worked great, but it caused you to have a stroke. It took years to stop those things too. So I think the idea is the last piece to do this. So they compare the differences by looking at studies, not by doing the study of the cells. They're looking at percutaneous renal artery stenting versus medical therapy alone. And they did a big Medline search and looked at all the usual trials. And then they had researchers look at the results. They looked at lots of citations. This is a bad thing about doing studies this way because they looked at 1,560 citations, which is a huge amount for 6 people to do. And now that 189 came, so you can see this. These studies sound easy to do, but reading 1,000 citations is almost 2,000. They looked at some clinical styles. They looked at case reports. They tried to get as much information as they could to see if this is a good thing or not. Overall, the evidence does not support a benefit from doing angioplasty over medical therapy, but there's also the side notes. So the side notes, one is we always teach, especially in diabetics with flash pulmonary edema, think about renal artery stenosis. So you have renal artery stenosis, alteration of flow, less flow to your kidney, something like surge goes along, your ventricle becomes stiff for a bit, you go into flash pulmonary edema, and we think of renal artery stenosis. They have a classic nephrology sort of thing. So for students, people develop pulmonary edema that didn't do something, right? They didn't just get IV fluid from us. They didn't just have a heart attack. Flash pulmonary edema is one of those common things. So in those cases, they're saying, well, maybe you should really still do it. Maybe it makes a difference. Scleroderma does this sort of same thing. Also, people with very high blood pressure you can't control, you try to do this as a salvage therapy. It hasn't been proven to make a difference, and most of the trials are done with fairly severe renal artery stenosis, so your really benefit from that's pretty low. And then if you have worsening kidney function. So I've had patients that, their kidney function's worsening, they have a GFR of, let's say, 22, and you open their arteries and it stays open for another 2 or 3 months, but they still end up in the bad spot anyways. And we'll do that sometimes. Now, in a bigger societal issue, is that worth it? So they're off dialysis for 3 months, but you just spent lots of money to get them off that. That's a good question that no one's going to study right now. So bottom line for this study was that there is really no role any further to do renal artery stenting unless in the case of progressive renal insufficiency, flash pulmonary edema, or blood pressure you can't control. Otherwise, this should be the last thing for the study. Yes, Dan? It does. It's stenotic, and then the idea is for some reason your blood pressure drops for another reason. Something else happens. Yep. So it's you should tell patients, because it's kind of weird, right? Because your kidney senses your blood pressure. So with renal stenosis, it's like putting the thermostat for your house in your screened-in porch. That's right, because what's in the body has no idea what the blood pressure is, so it tries to increase your blood pressure. And then something weird happens. Diabetics are more famous. I think it's because of volume shifts that happen. Anything before we fly off? Any questions? It is. If I have that number, 70 years old smokers, very high. And around here, I would say it's even higher. So one of the big things, hypertensive nephrosclerosis is very common around here, I think because people live so long. So while they may not have renal artery, they have lobular artery stenosis. It's very common around here. And as for hypertension, it's a very common cause. Yeah. And the problem, yeah, I think so. So it's a typical sort of thing. So aldos are unusual, pheos are unseen, right? And then when you end up in a hypertensive clinic, they become very common. So in my world, they're pretty common because I don't see normal blood pressures. Does that make sense? So when we were opening them up, I see one a week or so. So it's pretty common, especially in that age group. I mean, cardiovascular disease, men, is very, very common. Yes, ma'am. So it depends. Like the wrist ones, you mean? Yeah, I'm not a big. So wrist is hard, right? Because it's compression. So these blood pressure groups work compression and hearing sounds as they beat, right? So it's really what they're really measuring. There's no, I shouldn't say sound. So there's no acoustic component to this. This is just your arm gets bigger. It's almost like impedance issues. So it depends on your wrist. If your wrist is really thin, that's not going to really do much difference. If your wrist is kind of heavy, it works. So I'm not a big wrist cuff fan. But yeah, they tend to bring it up here. But classically for blood pressure, it's supposed to be downside and supported. So you'll see nurses do this, right, and hold your arm like this. So the question is that right or not, I don't know. So one thing that comes up in our world is CPP, cerebral perfusion pressure. So for years, we've been talking about perfusion pressure, which is in between the MAP and the intracranial pressure for decades. Then some smart fellow goes, but MAP isn't the right number to follow because that's the blood pressure here, not here. So you're right, we should measure blood pressure here for CPP because that makes more sense. That would be cerebral MAP. But all our studies are on doing it down here. So while this may not be the best way to do it, this is now standard, and there may be better ways to do it. Like maybe we shouldn't take blood pressures in the office anymore. Maybe we should do it ambulatory only. But we're stuck with this thing. So that answers your question. I think we're stuck with this because no one's going to do trials differently. Yep, I usually tell them the cheapest thing is just buy a blood pressure cuff and have a friend take your blood pressure. That's the cheapest thing to do because it's like $10, $15. And then for maybe $50 or $60, you can get the automated ones you put on yourself, you pump up, or sometimes you push a button, it pumps up. Or if you want to spend lots of money, you can push a button, it pumps up, it brings it down, and then sends it off by Wi-Fi for like $200. So the simple ones like this, I have one that works with my iPhone. It's like $100 and it records back and forth. It's very easy to use. But I think it's a much better way to do blood pressures because you're calm and relaxed. Right? So I think it's interesting, though. I mean, again, this is a God we pray to, right? I mean, this is something that number is so important, and no one goes back and goes, well, I wonder if this number is even very good, and not. So unfortunately, societally, right, for societies that either put out guidelines or, more importantly, grading systems, that's just that one number, and that's what you get recorded. Okay? You're welcome. Right. Porta bodies? Yeah. That was a cure system for a while. The back of the head they did for a while. No, it didn't turn out. Though Pat Kelly, he's doing all these things. He has a new thing he's working on now in his wrist. That'd be very cool. That would be, yeah. Something like that. I'm excited about that. Everything he's done is really cool, but this is huge. Mm-hmm. Yeah. Right. Yeah. Right. So, right. Well, I mean, it'd be different if you were just doing medicine to treat somebody, but unfortunately, these guidelines. So, I mean, if it's 141, do you increase medication? It's 1 point off. Yeah. It's very, very hard. The library. I don't. Free? Really? So you just go, no, I didn't. No, that's really. I spent all this money on iTunes on buying these books, right? Because